Today I'll discuss the case of a young woman who presented with recent onset of right hip pain. And I always clarify when people talk about hip pain because people use that word differently. She pointed to the groin and primarily the buttocks area, the lateral buttocks on that right side. And I'll go through the verbal history, the physical exam, and the treatment. The course of care was 3 visits over the course of about 2 weeks. So, like I said, presenting with recent onset, and recent onset is helpful in this case because I think it highlights how if you catch something when it's new, the course of care to reverse it is typically much shorter than if the problem had been long-standing. So she had been hiking a week before I met her, onset of right glute pain with the drive, and a small flare-up of her low back pain. Her low back pain, of course, I'm going to pry into that because so often hip symptoms and signs are due to mechanical problems or other problems in the lumbar spine. The XBOS study, I think, found that 71 or 72% of people with isolated hip symptoms had their symptoms reversed with movements of the low back. XBOS meaning extremity pain of spinal source. That's how that study's name is abbreviated to make it kind of more memorable. That XBOS study, I believe, is free online. It's a nice look at people presenting with isolated extremity symptoms and how much of that is resolved with moving the low back or the neck versus moving the extremity itself. And those patients differ from her because she also has simultaneous low back pain. But to her, the low back pain is separate and not her main problem. So classifying this presentation would be a primary complaint of right hip pain or groin and buttock pain that wraps around. So when I pried about the low back pain, which of course I'm going to do in this case, 5 to 6 years ago, it started. It used to be especially problematic in the mornings, and it would be across the low back, not one side worse than the other. In the past week or so since the hiking, the pain in the hip area has been getting worse, and there wasn't like a trip or a fall or a specific trauma. It just happened when she was gone on that trip, hiking and driving to and from. Worse with bending, worse with squatting. When she walks, her hip will pop. Better with standing, although it's still there, that pain, and better with lying on her back. In her normal life, she has a sitting and standing desk at the office. She bikes for her commute, and she does yoga and Pilates in her free time for exercise. In the past, she had attempted physical therapy for the low back, which was somewhat helpful, which focused on hip strengthening as the episode of care. And she'd used naproxen in the past as well for the low back pain. So in the verbal history, to me, this sounds like a lumbar problem, creating now referred complaints into the hip area. Like I said, pinning down what someone means when they say hip is important. Buttocks is not hip to me. Groin is not hip. Hip is kind of that lateral part of the upper thigh where the hip joint actually is, where the femur meets the pelvis. And we know where lumbar spines typically refer symptoms, and we know where hips typically refer symptoms. Hip problems do typically refer anteriorly groin, sometimes staying in that lateral compartment, but they don't very regularly refer symptoms to the buttock. So when I'm thinking that the most pronounced symptom for this person's hip complaint is the lateral buttocks, I'm thinking more, it's stronger of a likelihood that it's lumbar. Obviously, the concomitant lumbar symptoms are a big check in the box for is this lumbar versus hip in the lumbar box, and a prior 5 to 6 year history of lumbar complaints. So x-rays in the past, but no other things that make me curious about red flags or, for example, fractures or acute structural lesions in the hip or the low back or non-musculoskeletal things. So moving on to the physical exam, when I adjusted her posture in sitting and I placed a lumbar roll behind her, her complaints were better. Her hip flexion strength was 5 out of 5. Hip abduction strength was 5 out of 5. Dorsiflexion on that right was 4- out of 5. Femoral nerve testing in prone with the moving the foot to the buttocks was negative. The foot could reach the buttocks. And negative bilateral straight leg raise passively tested. It was about greater than 90 degrees, I wrote down. So negative for nerve tension tests in those two varieties. In the hip itself, for the right hip, active and passive range of motion, I put moderate loss of flexion secondary to pain. And I didn't do it passively. I asked her to use her own hands because it was so painful. And she just couldn't bring it up to her chest because of the pain. So moderate loss of flexion. And then on the left side, the hip internal rotation had some end range pain, but the end range pain was pronounced on the right side of her hip, or the right hip. So that's a little bit of an odd finding, but no other range of motion losses or problems. The low back, I look at 4 motions in standing. Flexion is touching the toes, so I have patients keep their knees straight and go down with their hands as far as they can go. If they can't reach their toes, I want them to put their hands along their lower extremity so I can see, is it the top of the shins, the mid shins, the top of the ankle, the top of the foot, etc. I can mark using those kind of points as how much motion they have versus using, which I also use, minimal loss, moderate loss, major loss, but I can really kind of quantify it by where their fingertips reach. She could get her knuckles to the floor. She felt a low back stretch, and it was more in the right versus the left. So that's very important, right? Stretches should be bilateral, uniform, symmetrical if they're really getting normal tissues to stretch to their end range. But if it's more on one side than the other, that's a symptom. And she felt awareness in her right buttock when she went down to full lumbar flexion. Extension, which is trickier to measure, of course, because we don't have that hand placement or any other kind of distinguishing factor. Maybe you can put someone with the wall behind them and kind of see where their head goes. But I use min, mod, major loss for patients, and I base it on what I think that patient should get for that person's age range and gender and maybe athletic ability. There's kind of lots of factors where I kind of assume on day one, is this minimal loss? Do I think it's moderate loss? It doesn't really matter at the end of the day what I think it is on day one. It matters, does it change? And then we can get to the point where, well, if we can't get more, then you have no loss. But it's an investigation. We don't know. It's not like knee extension or shoulder flexion where we can measure it to the other side. And we know that lumbar extension and other motions of the lumbar spine are variable from person to person. So we're looking for change. We're really looking for change, but I still need to kind of put down something for what it is on day one. For her, I put her low back had moderate loss of extension, especially when you think about someone who's getting knuckles to the floor in flexion. You want to see a lot of extension, and I did not. Side gliding to the right and left were full. However, when she did left side gliding, so moving the hips right, the left shoulders, or the shoulders going left, that's left side glide of the low back, she felt an aggravated or an aggressive stretch on the right hip. So moving the other direction was fine, moving that direction was not, so we mark it down as a finding. That was the physical exam. Repeated movement testing was the test I chose to use for her in the testing portion of the exam. I wanted to do repeated movement testing of her lumbar spine, of course, because if there are complaints in the low back and the hip, I'm definitely starting at the low back. And we did 2 sets of 15 extensions in prone with a hip sag. I thought it was important to get to that kind of sagging portion of the overpressure quickly. It would produce during the motion. She would get some symptoms going up during the motion, but not remain worse. After, we saw an improvement in forward bending and standing for lumbar spine, improvement in extension, which we were after, decreased a stretch with that left side glide, that feeling of a stretch, improved hip flexion range of motion on the right, and dorsiflexion on the right was now 5 out of 5. So this is one of those cases where you see almost all, if not all, baselines improve. That's pretty profound evidence that we're doing something right, although the proof will be kind of borne out over the course of several days. I also did some gentle mobilizations in prone. some extension mobilizations of the low back. When I say gentle, I mean maybe 30 to 50% of full force. I wanted to see, because I hypothesized that that would help her along, meaning get her moving more into extension and speed up the recovery process. And it seemed like that was fruitful. Her homework therefore became extension in lying, lumbar extension in prone, with that hip sag at the top. Lock your elbows, breathe out, drop your pelvis down as far as it will go, adding that bit of overpressure to help us get to end range faster. Do 10 of those every couple hours and use a lumbar roll when she had to be seated. She came back 5 days later. She said she was almost 100% better. She'd been doing the extensions and lying 3 to 4 times per day, not the every 2 hours like I had asked. The lumbar roll had arrived. She uses it on her couch at home, and then when she's in the office and she sits, she uses a wedge under her to help place her low back above her knees to reduce that pressure, hips and low back above the knees to reduce that low back pressure inflection. Her physical exam was significantly better than the physical exam 5 days prior. Ankle dorsiflexion was now staying at 5 out of 5. Hip flexion, internal rotation, external rotation, all within normal limits. Full range of motion, no pain. Lumbar flexion stayed great. Lumbar extension, I put her as still a minimal loss. I don't think we had restored it to her 100%. That was my hypothesis, but not significantly, moderately obstructed like it was on day 1. Side gliding right and left, still full range of motion. And now she feels a mild strain in her right hip when she does the left side glide. So not as aggressive as before. Her homework, I asked her to show me what you do for your home program. Her demonstration was good. Then I decided to look at sustained lumbar extension. My thought process for that is I also want to see if too much extension is, or if more and more extension is good, or if we have plateaued with the improvement with extension and now more extension is not good. My hypothesis based on her presentation, her verbal history, her physical exam, her change in 5 days was that extension was what she needed, and therefore more extension would be even better. So I put her in sustained extension on blocks, elbows up on yoga blocks for about 2 minutes, and it improved her extension in standing and abolished that hip stretch on the right with the left side glide. So that was enough evidence I needed that we were on the right track. I mean, we already knew if she's almost 100% better, we're on the right track. But I had more evidence to convince me that prescribing more extension for more days was the right thing to do. I said, I'd like you to continue with the extensions with the hip sag 3 times a day. And the other 3 times a day, I'd like you to do some sustained extension on the blocks with at least 6 inches of books or blocks under your elbows, more if possible. And to reincorporate yoga, reincorporate Pilates and biking to and from work, which she couldn't do as able. She presented 9 days later for the 3rd visit. She had done the sustained and the extension in lying, but she did them kind of together. So she did a set twice a day of the sustained and the repeated, and then later in the day sustained and repeated. She could feel some pain getting out of it in the morning, but not in the afternoon set. She used the lumbar roll. She went on a hike, and on 2 days prior to me seeing her, and it was with a 2-hour drive, and she said she felt fine, and she was surprised that she felt fine, and attributes some of that success to getting the car seat ergonomics better, especially using a lumbar roll. She did try Pilates. She felt some tweaks in her low back, but she was fine the next day. Physical exam was great. Dorsiflexion was fine. Hip range of motion was fine. Lumbar range of motion was fine. Her extension looked better to me, and I think that it was her normal range of motion. So I said I wanted her to continue with 3 times a day doing some lumbar extension and trying to increase the height if she chose to do sustained versus repeated. Try Pilates again and ensure that it's pain-free. So I wanted her to be a normal human being with pain-free life in daily life and pain-free Pilates before we reduced the dosage to a maintenance dosage. 3 times a day, is still considerable in someone's life. Maintenance dosage, as I've mentioned before with other patients, is what works for the patient. The goal is to keep full range of motion, and therefore pain-free life. So if that's the goal and you need to perform lumbar extension 3 times a day to keep your pain-free lumbar range of motion full, then you need to do it 3 times a day. If you only need it once a week, then you only need it once a week. If you understand the goal, then you can calibrate how much you need that movement in your life to keep that range of motion. So that's what I told her. I was like, it could be 1 time a day. It could be the days you sit a lot. It could be you just do it like clockwork every night before you go to bed. It could be once a week. It could be after long drives. But if you understand what I'm teaching you, which is look how much lumbar extension you have compared to day 1. Look how you can get your knuckles to the floor. Look how you can go left and right with no pain, with great excursion. We want to keep that. So the maintenance dosage is really individualized. Personally, I've had 3 significant disc bulges or herniations, or what I would say mechanical disc derangements, mechanical joint derangements in my low back that really affected my life and my ability to function. For me, it's 1 to 2 a day on average. It takes just a few minutes. It's easy to incorporate. And on the flip side, I sit up straight. I monitor my range of motion on a regular basis. I don't check my range of motion every day, but every couple of days I'm making sure, especially when I'm in the gym, that I have full range of motion of my lumbar spine. And that works for me. That's not going to be the plan for everybody, but I know how to keep my lumbar spine moving well with simple exercises and attention to my lumbar positioning, especially in sitting, especially in cars, especially on couches. I just learned how to sit up straight and keep the natural curvature of my spine. And I think that's really germane for a lot of patients, is to understand what position your low back is in on a daily basis and how that relates to loss of range of motion if you have loss of range of motion. So she was going to be out of the country and agreed that she would let me know when she was back in the country if she needed more care. But again, being almost 100% on visit 2 and staying close to 100% with the added challenge of a Pilates session on visit 3, she was doing great and I don't have concerns. It seemed like extension was her directional preference. A couple of the other factors in the physical exam that make me think it was extension, or at least something in the sagittal plane. If I think it's in the sagittal plane, we're going to think it's largely extension, because most people get worse with flexion. Most people rarely get extension in their life. But also she had no loss in side gliding, so no loss in the frontal plane. And she had significant loss in extension and no loss of flexion. And her hip kind of findings, yes, significant loss of hip flexion, but there was not major problems in the hip. So that's another reason why I thought it was lumbar. If I'm thinking it's a hip problem, I'm typically going to find more than one finding in the hip. In this case, it was just hip range of motion and flexion that was a baseline that was positive. So for those reasons and others I mentioned earlier, I'm thinking it's lumbar. I'm thinking it's sagittal plane. If I'm thinking it's sagittal plane, then I'm thinking it's extension. And her worst section, of course, was also, I feel worse when I bend, which is hip flexion and lumbar flexion. I feel worse when I squat, which is hip flexion and lumbar flexion. I feel better lying on my back and a little bit better standing. Those can be neutral to extended, maybe a little bit of flexion depending on how she lies on her back. But we use the verbal history, we use the physical exam to decide what are we thinking diagnostically, and therefore what tests would be important, right? If I'm starting to think, I think this is a fracture, the testing that would be salient would be an x-ray. If I'm starting to think after the verbal history and the physical exam, I think this is a tumor, well then we would like further imaging, maybe an MRI, maybe CT scan, whatever the person who does the imaging thinks is the best image for that. But her evaluation made me think this is a kind of rudimentary, commonplace mechanical joint problem, which I can propose is thinking of a joint as being tweaked. And we can get into the pathoanatomy, which is not that well established, but I tend to think of these as disc derangements. Something in the nucleus and the annulus is not moving correctly. We need to apply pressure in a certain direction to get it moving correctly. That, of course, remains up for debate. But in general, you can think of a joint not moving well. And why is it not moving well? Maybe it's the facet not moving well. Maybe it's the disc not moving well. Maybe it's something extra articular around the joint. Again, I don't get into those debates, but I know what I think is happening. And I think the anatomy that's affected in these situations is the disc. And I think there's evidence to suggest that we are affecting the position of the disc with certain movements, but that's not black and white quite yet. But her diagnosis after all this is a mechanical joint derangement in the lumbar spine that responds to repeated extension in prone, or has a directional preference of prone lumbar extension. So again, I think this does highlight as a case that if you can kind of catch these things quickly, the course of care is generally going to be faster than if you have a problem that's been there for a long time. Those courses of care can take longer. And I generally think of someone complaining of kind of hip and low back symptoms as being a little bit more challenging, because you have to figure out, is this lumbar and hip? Is it just lumbar? Is it just hip? And those can become challenging. But in this case, it was all lumbar, and it was also referring symptoms to the hip area.